Okay, now I've started. Okay, so, but we're also going to cover a couple of things to do with the grant, because I need everybody to be very aware, including our faculty who are not here, about this grant. So we'll have to have a special session for the ones who are not here. I know they'll love that. But everybody on the geriatric medicine faculty has to be able to talk about this grant. You're going to have to be able to use the slides. And Milton, did you want slides? Were you one who wanted?
Yes, I did. For this Saturday.
So you want to get them now? Have you got something to get them on? Can I email them to you at the end? Okay. I thought it was you, but I couldn't remember who wanted them. Okay. So, but it's not this set of slides anyhow that you want. You want my other set. So this won't help you at all. So I the other set I'm going to send you. Okay, so basically we've got this ridiculous grant of $840,000 a year for 3 years, so that's each year. It's a lot of money. It goes mainly to pay faculty salary. This is why the faculty have to be excited about it, and they have to want to know about it. They have to go and talk about it because they are getting a lot of money. So is Dr. Grossberg, by the way. So all you guys are here to pay to do the work for George. We understand how this works, okay? But basically, and one of the things that HRSA expects out of this is a 90% compliance in the whole of Missouri, that people over the age of 65 will be screened at the end of the 3 years for cognitive dysfunction. Now, I know all of you know that's not going to happen, okay? I know it's not going to happen, but that's the aim, that we're trying to get at the 90% screening. So that means that everybody in Missouri needs to be screened, and we're going to do lots of screenings, lots of things, and at least in the areas we promised to screen, we hope we'll do that. The way we're going to try and get this done is we're pointing out to all the physicians that this can be part of the Medicare annual wellness visit. And I'm sure none of you actually know that you get paid $172 for the first time you do it, and $117.11 after you do the annual wellness. You can do it once a year. That actually is a lot of money. Residents don't care, but everybody else, it's a ton of money. I mean, this is a lot of money for physicians for a visit, and we're looking at making it a very short visit. The visit has to have a health risk assessment, provided consultation and personalized prevention plan. We believe that we can do most of this using a healthcare person, not a physician. And this is where we're trying to go. And what we've developed is something called the Rapid Geriatric Assessment. Many of you will know this exists, but just to remind you, it's to look at frail, it's fatigue, resistance, aerobic illness, and loss of weight. That takes at least 15 seconds to screen for. The sarcopenia questions are over there. The SNAC is looking for anorexia, and the rapid cognitive screen is the one that George and I and Ted Maelstrom and a variety of other people have validated here at St. Louis University. And that's 5 questions. It's the clock, and then you ask them what the 5 words are they have to remember, then the story, and they've got to be able to answer that the person lives in Illinois, though you've told them Chicago. It turns out that this works almost as well as the slums, and far better than the mini mental status at picking up MCI. So very quick. The mini card, which is one is the clock and 3 words, doesn't come close to picking up MCI. The 5 words are very valuable, and for executive function, turning Chicago into Illinois is very valuable. So those are the things that make a big difference for those of you from psychiatry. And it turns out, as I say, not quite as good as the slum. Slums take 6.5 minutes. This takes 2.5 minutes to do. So, we're getting down to nothing. I don't think we can get shorter than 2.5 minutes. There's some other questions we're going to ask about constipation and incontinence, but also importantly about advance directives. Because as of September, CMS is going to pay for a discussion of advance directives. So if the patient says, I don't have advance directives, you can set up another appointment for them to come and have a discussion about advance directives. So those things work out fairly well. We have information sheets that we can give out to people. So when we screen in the community, if you screen positive, you'll get an information sheet, whether it's for frailty, sarcopenia, or brain health, and we put together a number of other different things of what people can do, but also what they should ask their physician about. Ask about possible causes, monitoring, treatable conditions, depression, sleep apnea, hypothyroidism, vitamin B12 deficiency. So the concept is that we will use the people in the community to go to their doctor and say, what's wrong with you? You haven't screened me for this. And they tell me I've got it, and you should maybe do these things. I've got great belief that the easiest way to teach a physician to do something is if enough patients go and complain they're not doing it. Okay. I should point out to you, well, I'll do that in a minute because it's coming up. So we've also got algorithms for the management of both frailty and also for brain health. What I want to point out to you here, they're simple. They're going to be put into the computers at SLU, at SSM, at a number of other hospital sites, and we're making them freely available to everybody who wants them. One of the reasons we finished up using the rapid cognitive screen and not the 88 is when I asked John Morris at Washington University, could we use the 88 as a screen, which, by the way, does not pick up MCI, just in case, because he will tell you it does, but while I was in Singapore, we showed it doesn't. So at least in Singapore, it doesn't pick up mild cognitive impairment. It only picks up dementia. But basically, we were going to use it because it's quicker, but they won't let us put it into the computerized record. They want, in a computerized record, they want money for it. These are all free, and then you can use these to try and help the physician get answers. You'll see one of the things here is if you say you're fatigued, but also it's the same thing as if you say that you're anorectic, so you score high on the SNAC, or basically you've got cognitive dysfunction. The first thing you've got to screen for is depression, and basically what we're going to put in for the depression is Dr. Grossberg's I'm Sad, which hopefully you've all, any of you not seen Dr. Grossberg's screen? Please tell me I'm teaching you guys about Dr. Grossberg's screen. No, you've seen it, right? No? Yes? Maybe? Okay. So it's very simple, and they've validated it as a reasonable way to pick up depression. We're not doing it as a screen. The reason being that if I send out a medical student and a nursing student or a social work student and they get a positive and the patient is very upset, we don't believe it's something that should be done as a screen in a community. So we don't like the concept of screening for depression in the community. We want a healthcare provider who knows what to do if the person says, I'm going to kill myself. Makes sense? So we're a little worried about that. That's the reason it's not there. Please let George know that, because George is all upset that it wasn't in the primary one. There was a reason behind it. Actually, I only thought of the reason after he told me he was upset, but that's okay. Okay. So the next thing I want to tell you about very quickly before I get to what I really want to talk about is basically the brain health paper that's come out the 1st of September. So you should all know about the JAMDA. This is a paper that was a consensus conference that was put together by John Morris and myself.
Bruno Bellis has most of the major experts in the world who were involved in it, including the Alzheimer's Association. And the Alzheimer's Association has an editorial in the next issue which is saying this is a wonderful thing. Okay, so we're getting a lot of buy-in to it. The things that you need to know about it, the major conclusion was that case finding by physicians and health professionals is an important step in enhancing brain health for aging populations throughout the world. 60% wanted basically screening of the panel, 40% wanted case finding. To actually get the 40% to agree, we gave up and went to case finding. So you can argue whether you screen or you case find, but we're going to actually be comparing both of those in our education anyhow, so we'll know. We think anybody who's got a problem should be picked up early. We'll explain why. The conclusion is in keeping with the position of the Medicare and Medicaid services that reimburses for detection of cognitive impairment as part of the Medicare annual wellness exam. So that's
one of the reasons, and also for the international call by the Alzheimer's Association for early detection of cognitive impairment as a patient's right. And why would you want to do this? So that's always the thing. So first of all, can we do it? The panel agreed that there were validated screening tests that took 3 to 7 minutes, that included the mini-cog, the RCA, because they did not actually care about whether you could pick up cognitive dysfunction. They cared only about dementia. This says that people who are experts in this area don't know very much. Okay, that's what's my version, but they will get there. Yeah.
So when you say case finding, back to the previous slide, you mean someone comes in and says, my mom has...
No, it means if somebody over the age of 70 comes to see a physician, 20% have memory dysfunction, or comes to see a healthcare professional, you're going to case file. You should have. I mean, when 1 in 5 of your population, and I'll explain why in a minute, that's case filing. It just means that they don't agree that you should go and stand on the street corner and say, hey, come here and see if you're cognitively impaired. Or as we're going to do, go to churches, have health fairs and stuff. And that's the other piece. But we can't meet the yeah.
I think the question is, what's the difference between screening and case filing?
Yeah.
Well, that's what I'm trying to tell you. Screening is I go stand on the corner. Anybody who wanders by, I screen. So I offer to screen anybody who wants it. Case finding means that the person is at high risk and is being seen by a health professional. They're not hugely different, but there is a difference. So
it's just wording.
And the only reason, by the way, that case finding, there wasn't anybody who didn't think we should really screen. It was the neurologists as a total group. All the neurologists said, you can't do this. There are not enough neurologists. If you find all these people, we will be swamped and we won't be able to do our job because there are not enough of us. I think that's a very bad reason. Okay, my personal opinion is it shocked me that the reason not to do something is it's going to increase the potential work for people. So that didn't help me very much. But neurologists think that way. They don't want more people with Alzheimer's. Okay. Yeah?
Yes. Well, the other thing is, does this document address the United States Preventive Services?
Yes, it says roughly nicely it's trash. Okay. And explains why, and I'll show you. And of course, no, I mean, you read the document, it's very long. It's very well done. A lot of help from Mary Gangley, who did the DSM-5. She put a huge amount of effort into rewriting it, and a large amount of work from 2 or 3 other people. It's very comprehensively covering all the things and why the U.S. Preventive Task Force doesn't know what they're talking about, which I'll show you in a minute. Okay, so a combination of patient and informative-based screens. So we've got things that are patient-based. The informative-based would be the John Morris AD8 from Washington University. You've all seen the AD8. You all know what the AD8 is. I mean, I'm assuming you all do geriatrics. You know this stuff. AD8 is 8 questions that ask you, the caregiver, is the person demented? They're things like, do they forget where they leave their keys? No, not that one, but, are people forgetting things? They're simple. They do pick up. The 88 picks up very nicely dementia. And it's a very strong way to pick up dementia. It just doesn't pick up MCI, despite John Morris's belief that it does. Okay, and the data we got with full psychological assessment in Singapore shows it clearly doesn't come close. If you look at the questions, you know it can't anyhow. So you should do both according to so we should add the 88 to our assessments in the clinic, by the way. We should be doing that and adding it. It's an important component of geriatrics as people see it now. Early cognitive impairment. This is why the Preventive Task Force is wrong, number one. There are treatable causes of early cognitive impairment. Once you have treatable causes, not to look for them is inappropriate, no matter what, if you're a physician, because if you don't look for them, you'll get sued. Okay, sleep apnea being the number one. Okay, if you don't look for sleep apnea in people who've got cognitive impairment, and somebody finishes with Alzheimer's and they show he has sleep apnea, you can be sued. You're not going to win that case anymore because it's such a big cause of early cognitive impairment. Emerging data supports a combination of Medicare and lifestyle interventions as a potential way to delay it. So this is the way to delay it, and while this wasn't published at the time, everybody in the group knew it was coming up. And this is the finger study. Do you all know what the finger study is? Have you guys seen the finger? So finger is Finnish Geriatrics, okay? So it was done in Finland. They took 60 to 77-year-olds. They had a 2-year multi-domain intervention, diet, exercise, cognitive training, vascular risk monitoring, or a control group with general health advice. They had a relatively large in each group. You can see that this actually improved outcomes, processing speed, executive function in particular, really well. I mean, over 2 years. These are dramatic changes in this population. So therefore, there is evidence. There's another paper coming out of Toulouse with Bruno Vellis's group that I've seen that I'm not supposed to tell you about, but it's showing the same sort of thing, that combination therapies, not a single one, but when you put them all together, you can actually get very good outcomes. So we can't say there isn't evidence-based medicine anymore. So this is just showing you that if you have fruits, vegetables, olive oil, a big piece of these diets, by the way, a liter a day from the Primado study, the Spanish study, a liter a week, a lot of olive oil, okay? That gives you diarrhea if you're an American. You can't help it. But for real people, Spaniards, Italians, they have no trouble and Greeks, they can manage a liter a week, okay, per person. You're going to have exercise. If you look at JAMA, the life study just came out for memory, and what it showed is it didn't work. The life study was a pretense at exercise. And they actually put this buried in the discussion, that there was so little exercise, it didn't actually work for exercise either. It worked a little bit for exercise, but it failed to do their primary things that they wanted, which was the SPPB, because it was minimal exercise. This is, as you see there, lifting weights and resistance exercise, aggressive exercise, okay? And then computer games and socialization. Those improve cognition when put together. This is the table in the brain health. Spend enough time with the patient and, when appropriate, family members to assure maximum understanding of the condition and recommended care. Provide written instructions. One of the things you've got to realize, if you happen to come to our diabetic clinic here with the endocrinologist and you're 50 to 60, 20% will have cognitive impairment. The endocrinologist will have no problem to tell you, you've got to prick your finger 4 times a day, you've got to adjust your insulin based on that finger prick, you may have to take metformin, you should take a statin, you should take 2, 3, 4 antihypertensive drugs, and they'll do all of this in about 10 minutes. They'll then send you home. We actually did a previous study where we had somebody stand outside the door, a medical student. When people came out, they asked the endocrinologist, asked the person what the endocrinologist changed, and 70% could not remember a single thing the endocrinologist had told them to do. Now we're showing that 20% of these people are really cognitively impaired. If you're cognitively impaired, it's useless for a physician to tell you what to do. They've got to write it down, they've got to talk to your caregiver, there are a whole series of things, and that alone is a reason to screen when you see a physician for cognitive impairment. The same is, by the way, totally true for heart failure. So that's the other one that the figures are virtually the same as for diabetes. Identify all potentially reversible causes of cognitive impairment. We talked about the things to do. Discuss the potential use of cholinesterase inhibitors. I don't think there's any, but if you've got Alzheimer's disease, it is potentially a usable drug. I don't believe that there's any data to support memantine as usable for anything, but Dr. Grossberg and I disagree on that one. But cholinesterase inhibitors work about as well as CST, not quite as well. So maybe if you have no CST, you use cholinesterase inhibitors. We can argue about that one. Encourage the person to develop advanced directives. Very important. Another reason that the task force did not even think about, but it's very, very important because they can make their decisions. Educate the patient and family through recognized specialty organizations, for instance, the Alzheimer's Association. Address and take steps to avoid major risks associated with cognitive impairment. Can they manage their money? safe return bracelet, appropriate disposition of unsafe tools and guns, get them out of the house, and driving. All of these are issues that physicians and healthcare providers have to work with. Obviously, you need to know if the person can't function. Encourage identification and use support services. That's the Alzheimer's. Talk about potential research participation. So there are lots of reasons why you want to know, if you're a physician or a healthcare provider, that there's something wrong with a person. So the preventive task force was just trash because they could not think beyond a single thought. Their thought was, there's no drug that works. Therefore, we shouldn't do it. Well, drugs are not the whole world, okay, or anywhere close to it. So most of you, how many of you have not seen any CST? Do you guys know what cognitive stimulation therapy is? Have you seen it? Yes, no? I'm assuming the geriatricians, I've done it 20 times, Marla's done it, other people have done it, but have you guys had any exposure to this at all? Okay, so this is psychiatry at its best. These books out of Martin Orrell, he's a geriatric psychiatrist in London, and he and a PhD put this together. And these are books for group exercises for people who have got early cognitive dysfunction. And what he does with them is they are equivalent to Montessori for older people. They're brilliantly put together because they deal with stuff that works with an older person and the stuff an older person wants to know about, as opposed to something that a 6-year-old kid in kindergarten would want. But the level is very similar. They're done twice a week for 3 months, and they've been shown with and without exercise to really improve outcome. They are at least as good as acetylcholine esterase inhibitors, because I don't believe the number 6 for that, but it is true for the cognitive stimulation therapy, and they're much more cost effective. So CST should be available for anyone who's got late, early to moderate Alzheimer's, and that's where it works. Does not work when you've got severe Alzheimer's, but works very well in the late, early. And that's what our medical students are going to be offering free here. We're training them to be able to do this and provide it here, and so there will be a referral system that you can get people into. So that'll be one of the big changes. Obviously, we also, other reminiscence works with Alzheimer's patients, particularly a little further along sometimes, and the Alzheimer's Association has worked with us now to have the Cardinals Reminiscence League, which is baseball, which is a big thing in St. Louis. You know, everybody in St. Louis who's old knows everything about baseball, and they'll tell stories and stuff. So it's another way to engage people with Alzheimer's, and that's available, and you should be aware of that as well. This is just the algorithm for basically managing cognitive dysfunction. You should look for atrial fibrillation. Dulce Cruz and her colleagues show that hearing and visual problems are also a major component. You refer to the Alzheimer's, there's the CST, the other things that you should be doing there. Okay, so now I'm going to turn to psychoimmunology. So before I do that in the half hour, I would like to, the last half hour, any questions about what I just said? I mean, I know some of you have asked questions, but particularly for the psychiatry people, because we haven't done this before, are there thoughts or things that are worrying you guys? I mean, this is very much psychiatry I'm talking about. I tend to think of myself as a psychiatrist, and George is a medical person. We both cross over too much. Any questions or thoughts? You're okay with this? You'll remember the CST, you'll start to read about it, you'll hear more about it. It's really, down in Perry County, they have been doing this now for 2 years, and they're getting dramatic results in people. So they're getting them referred by the family practitioners. They do it as part of the hospital. It's paid for by CMS for the OTs to do. And they are getting huge numbers of people with extraordinarily good results. There's also an individual one-on-one CST. Can't talk about that at the moment, not enough time. But please, everybody's got to understand we're moving towards at least having something as good as Avocet, okay? Maybe better. If you add exercise, it's actually better. Okay, so George Freeman Solomon was a psychiatrist. He was a very good friend of mine. We worked together, and George is famous for many things. One, He wrote a book about his life, where he edited out all the nice things I know about his life, because he didn't think we should talk about that his boyfriend was once a president of the United States. But, that's okay. He used to get flown to the Canary Islands. He's dead now, so I'm not doing any. I love George. George had more stories than anyone. But the best story was he was paid by customs to come up with how to identify smugglers when they come through customs. Yeah, so that would be like, how do I identify a terrorist when you come through? And so George, being this thoughtful person who'd been smuggling stuff through customs all his life, described all the things he did when he went through. And so the next time he comes through, having put this out, and they've been teaching everybody how to do it, he comes through customs and they stop him and catch him full of all this stuff he's smuggling back into the country. So that tells you about what sort of a psychiatrist George was. The book is very cute, by the way. But the reason I'm starting with him is George actually was the first person who came up with the concept that when you have medical illnesses and you're stressed, your medical illness does worse. So he said, if a person is stressed, they've got rheumatoid arthritis, and they're very stressed, their rheumatoid arthritis does worse. So he tried to put together the brain and the physical into one thing. And he wrote a lot of articles on this and was very successful and came up with the term psychoimmunology. Subsequently, some people call it psychoneuroimmunology. So this is what he really said, but this is from Norman Cousins, who used to be the Saturday Night Post or something editor and wrote Anatomy of Illness, and he said the human body experiences a powerful and gravitational pull in the direction of hope. That is why patients' hopes are the physician's secret weapon. They are the hidden ingredients in any prescription. So what I'm going to talk about now is a very brief history of psychoimmunology, stress, and aging. I'll then talk about how endorphins, the body's own opiates, affect immune function. We'll talk about psychosocial events in aging, caregiver stress and immunity, and then the bidirectional effects of cytokines on the brain. So Oliver Wendell Holmes was actually the first person to recognize this. He said, healing is a living process greater than the influence of mental conditions. Greatly under the influence of mental conditions. It has often been found that the same wounds received in battle will do well in soldiers that have been beaten that would prove fatal in those who were just defeated, suggesting that the mind has a lot to do with physical outcomes. The first proof of this was actually in 1926 when Metelnikov and his colleagues in Paris used the Pavlov model and showed that you could condition animals to have abnormal immune responses. So you could create an immune response that in response to fear or pain, and you put it together with something that created the immune response, and then you took that away, and they just basically went ahead and had the immune response every time they were conditioned again. Robert Ada took this a lot further. Bob basically finished up pairing saccharine with cyclophosphamide in animals, and then showed that every time he gave them saccharin, you can come sit at the front or anywhere else, basically they would have an immune crisis. So you can actually teach animals and dogs and mice anyhow to become sick just purely by coupling something with something that makes them sick, and then every time it happens they get sick. So some of you, when you think you've got to come to work and you feel sick every morning, that's just because you've been conditioned to believe you should be sick when you come to work. Okay. So let's start off with endorphins and natural killer activity. So basically, the endorphins, the natural killers are the cells that go around and they get rid of viruses and bacteria and also cancer cells. So they're an extraordinarily important cell in the body for maintaining general health. They stop you getting the things you don't want to get. So many years ago, 1984, Neil Kay up there and I sat together and we said, I told Neil that beta endorphin would actually enhance immune function, and Neil told me, as most people when I tell them things, that I was totally stupid, I didn't know what I was doing, and I said, Neil, it's not going to take you long to test this. So eventually he and I went into the lab together. I brought the beta endorphin, he brought his natural killer cells, we put the two together, and gee whiz, in about half the people we stimulated, and the other half we didn't. So this was one of the big problems, because people were saying, no, it didn't work. They do 3 people, and maybe one sort of stimulated, but 1 or 2 didn't. And they said, well, this is nonsense. But what it was is, if you're scared of having blood taken, you increase your beta endorphins. And so therefore, once the beta endorphin increases, you've saturated the cell receptors, and it doesn't work anymore. So it only works in the people who are not scared of having blood taken. Okay? So it's a very early response to stress and to mild stresses. And then we showed that we could block this that with naloxone and opiate antagonist, and we showed that multiple different kinds of beta endorphin work, and that it wasn't actually the mu or the delta receptor, but it was a part of this of the beta endorphin molecule. And that's true for a lot of things. We tend to think the two ends combine to the receptors, but it turns out a lot of other parts of these peptides can combine and make a big difference. The same is true for beta amyloid, where the major memory-enhancing piece of beta amyloid is 18 to 21. I know all the psychiatrists know that, okay? And so basically, then we said, well, what if we give interferon? How does interferon work? And it turns out that beta endorphin actually combines with the interferon receptor and stimulates that. So if you block an opiate receptor, you're actually blocking the interferon receptor as well. So you could use naloxone to get rid of the interferon receptor, and then we showed the same thing with interleukin-2. So you cannot actually stimulate cells if you've got opiates. So opiates are very permissive in the ability of interferon interleukin to work. And then we showed that naloxone or beta endorphin would displace the binding of the interleukin to the natural killer cells. So we had a lot of evidence that these interact very nicely. And so the outcome to that was very simple. We sent the paper to 5 different places. Everybody rejected it, saying it's impossible that beta endorphin, which has nothing to do with the immune system, could possibly do this. And so we said, okay, that's life. So we put the paper away and decided it was never going to get published. About 5-6 years later, everybody started to publish that beta endorphin enhanced cells. So I said to Neil, everybody believes it now, you can send it out and it'll get accepted. And he said, I don't care about this stuff. And I said, well, I don't either, but why don't you just mail it to the best immunology journal you know? And so he said, okay, but I'm not putting new references in, I'm not fixing anything, I'm not putting the new references or anybody else. Mailed it out. Now, I've been going around the country talking, giving the talk I just gave to you, but spreading it out over half an hour or so. And basically, everybody knew we'd actually discovered it. So the paper went out, got accepted without any changes, and with references that were 8 years old at the time that it got accepted, saying that sometimes people are honest and recognize that they just stopped you publishing earlier on. Okay, so let's move on. The next thing we did is Maria Fiataroni, who's a very famous geriatrician now, Maria Fiataroni Singh in Sydney, was my first fellow, and she said she would only study exercise. So I said, well, if you're only prepared to study exercise, the only thing I'm interested in is I know exercise increases beta endorphin. Let's see if we can increase NK, natural killer cell activity. And we showed that we could, and if anything, it actually works slightly better in older people than in younger people, which was a surprise to us. And then we showed that we could block this with naloxone. So the next question was, if that's true then with exercise, what about if we did this with stresses, a simple stress test? So you have these laboratory tests, the Trier test and stuff, where you frustrate people and they get their catecholamines go up. And actually we showed that even with a very low level stress, you will actually stimulate NK cells, but it doesn't block with naloxone. What I'll tell you is other people have done stuff showing that this is due to norepinephrine. So it's both beta endorphin is the second piece of the stress response. As it gets a little more serious early on, it's norepinephrine. So now the question is, we've got all this information that the immune system is connected. So if you have stress while you're aging, does it make you more likely to get into trouble. And you can see here, looking at the presidents, you can decide if any of them actually didn't look stressed. Even George Bush looked stressed. So, I don't know why, but that's life. So one of the questions is the stress just an environmental stress? What about if your environment is bad? Does that give you a problem? So as you see here, something's just not right. Our air is clean, our water is pure, we all get plenty of exercise, everything we eat is organic, free-ranging, and yet nobody lives past 30. So this is Glasgow, and if you happen to make the mistake of living in Colton, Glasgow, versus Lenzie, so this is about from here to the 240. Okay, that's the distance apart. 270, yeah, one of those things. Okay, some stupid road somewhere. Okay, so, and this is basically showing you, if you live in Lenzie, you live to 82. If you live in Colton, you live to 54. Huge difference. That's the environmental stresses that make the difference, because they have free health care. Everything else is basically the same. The only real difference is the environment is terrible when you live in Colton, okay? And by the way, the same thing is true if you go from the inner city here to the county to St. Charles. People in St. Charles live about 3 to 4 years longer on average than the inner city, and the county is about 2 years longer. A lot of this is also due to environmental stresses. So if you live within 300 yards of a freeway, you're more likely to get Alzheimer's disease and asthma and stuff like that. So you never live near a freeway, okay? The same thing was shown when the Berlin Wall came down the opposite way. When the Berlin Wall came down, the people in East Germany were dying early. The Berlin Wall came down, and guess what happened? They quickly caught up with the West Germans. The West Germans didn't get worse. The East Germans just caught up very quickly. And this is an example in Hong Kong. Jean Wu and I did the study in Hong Kong. And what we showed in Hong Kong, which worked out really nicely, was that fundamentally, if you were in Hong Kong and they announced that Britain was sending Hong Kong back to China, the old men who'd fought, and that was what the old men there, many of them had come from China having fought against the communist regime, had a marked spike, a highly statistically significant spike, and there was another one in those 80-year-old men after they basically worked during the year they were going back. So it shows that even a small psychosocial stress makes a difference. And then Joe Flaherty did a study in Chengdu. They had an earthquake. He had been following with Dr. Dong there, Professor Dong, this population, and so the data was available. So we looked to see whether or not there was a change in 90-year-olds' mortality, not related to damage from the earthquake, but from basically the year following. And it turned out that if you have an earthquake, you get psychosocial distress. And George Solomon, who I mentioned at the beginning, did the same sort of thing with the Northridge earthquake. And he just showed that basically when there was the earthquake, he took blood from all the people in the hospital around him. And those, half of them were very distressed. They got real problems with their immune function. The other half didn't. So what we're trying to say is there's a frailty cascade, and that frailty cascade is psychological, social, and biological, that leads to one or the other form of frailty, functional deficit, hospitalization, nursing home, and death. And these all come together. That's extraordinarily important, I think, as we start looking at it. And so we came up with a social scale for frailty: sadness, outside activity, cognition, income adequacy, attachment to your neighborhood, do you like your neighborhood, or lethargy. And when you look at this, what we showed is people who are frail by this scale have problems with their activities of daily living, IADL, short physical performance battery, lower body functional limitations, one leg stand, grip strength, and they're more likely to die. So social things make a big difference. Dr. Cha, who's looking at the same population, is now showing that depression, untreated in the inner city population, causes much more mortality than if you treat depression. So this is the African American population. You treat them, whether they get better or not. So a lot of the treated people weren't that much better. They were still depressed, but they had a better outcome than if you weren't treating them. So the need to treat was very important. So this is just showing that the social frailty scale is very much associated with an increase in problems with particularly the tumor necrosis factors R1 and R2, which we'll show you multiple times are actually the major mediators of some of the peripheral physical illness as we go on. Important to recognize that whilst both social and physical frailty have the same outcomes over the same amount of time, they don't overlap very much. The people who have social frailty often are not physically frail, and vice versa. And Dr. Chow's showing the same sort of thing in the depression population, if I am getting your data right, that basically depression doesn't really say much about whether you're frail or anything, but it does make a big difference to your outcomes. So, now in the last 10 minutes we're going to cover caregivers, which was the whole lecture I gave as the Freeman-Solomon lecture, but that's okay. So I thought I'd show this first because what I'm about to tell you is the brutally honest memoir on caring for aging parents. It's hard, it's difficult, and it kills your immune system. Okay, that's the thing that you need to walk away with. Okay, and before I show you that, this is part of that grant. We have a caregiver stress screen. Marla Bergware and Sue Tebb had a big screen. She and I talked about this, and she decided that I might possibly be right, and that was too long, and we needed a much shorter one. So this is the short caregiver screen, and just need to recognize it's available. It does appear to have great potential to recognize caregivers who are at problems, and then you can do stuff with them. So Kiko Glaser, that young lady up there, when I was doing beta endorphin and NK cells, was doing caregivers back in 1991. And what she showed is that caregivers had more days of infectious illness, primary upper respiratory tract infections, and they had a number of immune system problems, proliferative responses to Con A and PHA, phytogluten, and the NK cells were not really reasonable. Then she went and looked at caregivers and showed that if you vaccinate a caregiver, they don't have a good response to influenza vaccination. So stress, you might as well not bother to give the influenza vaccination. It just doesn't work, okay? And then she showed that if you actually do cognitive behavioral stress management, you can actually suddenly get a very good response to the influenza vaccine. So just talking to the caregivers, making them feel good a couple of days a week, an hour a week, twice a week, will actually get the immune system back to normal. So this is, behavioral therapy, the stuff that psychiatrists forgot to do somewhere along the line and went to drugs. Seems to work really well. So this is showing the toll-like receptors and the same sort of thing, that if the toll-like receptors are responsible for turning on the bad immune system. That's what they do. And fundamentally, if you have cognitive behavior therapy, you just bring this back again in caregivers to normal. And here's another study looking at psychosocial enhancement of immune competence. Here we're looking at lysis of immune cells and the HRSA titers in the blood. So things that you can fix. And then Irwin, who's still a psychiatrist practicing at UCLA, he basically went ahead and did Tai Chi and showed exactly the same thing, that you could bring the varicella titers way down just by doing Tai Chi. Something that relaxes people, gets them relaxed, happy, you can improve the immune competence. Remember, the things we're talking about are the things that lead to cancer, to viral infections. Not necessarily early death, maybe late death, but you've got to be aware of that. And here, the immune dysregulation in caregivers is huge. The latent virus control, EBV, CMV, HSV1, shorter telomere length, which has got to do with cancer, lower blastogenic response, lower NK response to cytokine, and an increase in IL-6. Then she said, well, look, we need to show this has something really important, not just measuring these things. So she took people who were caregivers and controls, and she made a little punch biopsy in their arm. And basically what she showed is that the wound healing in the caregivers was much slower. So caregivers who are stressed heal wounds slower than other people. So suggesting that this is not a good thing to be a caregiver. So if any of you are caregivers, I'm sorry, it's not good and you need to get psychotherapy. Okay, that's all I'm trying to tell you. It makes a lot of sense if you look at it that way.
Does alcohol work?
You are the wrong person to ask that. Okay. So let's move right along. Okay, so the other thing to recognize is not only does the brain alter what happens in the periphery, but also the periphery can happen to what alters what happens in the brain. So if you have a pathogen, you turn on the innate immune system, you get inflammatory cytokines, they either activate the vagal nerve, circumventricular organ, or they get across the blood-brain barrier, they activate microglia. What I'm not showing you, is they then turn on the brain's cytokine. So the cytokine IL-1 in the periphery gets across the blood-brain barrier, activates the microglia, and turns on IL-1 in the brain. It sort of almost makes no sense, but that's how it works, and we've actually shown that. And this leads to sickness behavior, which is fever, anorexia, somnolence, malaise, depression, and you don't think very well. All of you who've had flu know that this stuff happens when you get sick. So think about it when you get really sick. So Bill Banks, who did these studies with me, and Sue Clark, we actually showed that the cytokines get across the blood-brain barrier, and there we showed the release of the IL-1 and basically used anti-human and anti-mouse antibody. It was a fun experiment, but you most probably don't care as much as I do about that. The next thing to recognize is if somebody's not thinking well and they are physically frail, they do much worse than if they're either physically frail or not thinking well. So you put the two together, first shown in older Mexican American in New Mexico. Here again showing the same sort of thing, bad outcome if you have both. Here are the neuropsychological profiles associated with physical frailty. So physically frail people actually have real problems as far as thinking. So this is true across the board. They're not as good at thinking as somebody who doesn't have physical frailty. And basically, if you look here, the big things are people who have problems thinking, they also have slow gait associated with this as well. So now people are talking about cognitive frailty. Cognitive frailty is a combination of both physical frailty and problems with cognition. It's reduced cognitive reserve, cognitive function not necessarily related to brain disease. They have a CDR score of 0.5, which is usually MCI, and they have evidence of physical frailty. What causes this? So there's a lot of argument, but if you actually look at the studies done by Pantoni and his colleagues in Italy, they have shown an incredible correlation between regional white matter burden, independent of cognitive decline, which causes problems with balance, gait, disturbance, and predicts falls in elderly, and then goes on to produce the MCI. So if you believe Pantoni, which I do because the Japanese and the people in Singapore all have the same data. So what they believe is that Alzheimer's disease is really vascular disease. Now remember, we're talking about places where they all have a lot of hypertension and vascular disease. That the vascular disease produces oxidative damage. It damages the pathways going through the brain. That causes cognitive dysfunction. And then it also increases cytokines. The cytokines increase amyloid precursor protein, and that increases beta amyloid, so that the Alzheimer's disease is secondary to vascular dementia. If you tell that to John Morris, he'll tell you you're crazy and you don't know what you're talking about, because he believes everything is Alzheimer's disease. That's only most probably true for young onset and a few older onset. Most of the older onset appear to have originally some vascular disease. So it changes how we think, okay? And people who have these white matter hyperintensities have worse cognition, worse executive function, depression, falls and balance disturbances, urge incontinence, functional decline, and disability. Okay, and it's related to cytokines again, not surprisingly. So the one caveat is the studies from Bruno Vellis, where he's basically shown that people who get large amounts of regional amyloid also have these problems. But I've already told you that most of the people who get large amounts of amyloid are already going to have some degree of vascular disease. So I think Bruno is wrong, but he's a good friend, so I'm not going to push it too much, okay? So the final things we have to know, and obviously peripheral inflammatory markers are increased in Alzheimer's disease. Which is the chicken and which is the egg? We don't know, but that's a big question we're looking at. But if you take mice and you give them a social stress, you increase cytokines. So it's again this bidirectional thing. I stress you, I have increased cytokines peripherally, that's great, but if I stress your brain, your cytokines go up as well. So it's very difficult to sort this stuff out. This is our data with cytokines and depression, Ted Maelstrom, and we found the only difference was depressed people have a marked increase in soluble tumor necrosis factor R1, and when we go look at the literature, tumor necrosis factor alpha is very strongly associated with depression. What comes first? We don't know. But you can argue that this is central causing problems, or you can argue that these are people who have increased tumor necrosis factor alpha, and that you would have to follow a cohort very carefully who have early depression, see if their TNFs are normal, and then as they get more depressed, run into trouble. So what I've hopefully told you is acute release of beta-endorphin enhances immune function in the elderly. Environmental and psychological stress has negative effects on successful aging. Caregiver stress is an excellent model for studying psychoimmunology of aging. So if anybody's interested, talk to Marla. Wave your hand at the back. This is, we want to do this, and we're most probably doing some of it in Singapore as well, but we're interested in looking at caregivers and seeing if, as we look at the stress, we can do things to lower the stress and look at more sophisticated immune functions. Sort of a great project for a fellow or a resident. Cognitive impairment and depression are models for bidirectional effects of cytokines. So I'm hoping I confused this sufficiently so I can now tell you that Emerson Pugh said, if the human brain was so simple that we could understand it, we would be so simple that we couldn't. And if you think about that, that sort of summarizes the problem we have in geriatrics and in psychiatry, because we're dealing with complex interactions and we're trying to call it one thing, and it's usually 30, 40 things going on at the same time. So hopefully that was somewhat enlightening for those of you who didn't know about psychoimmunology. It's a great field, I think. UCLA has this huge center of neuropsychoimmunology, which is funded by McDonald's, by Mrs. Kroc, who was McDonald's. So she gave unending money to study psychoneuroimmunology. So if you start doing it, you can go to UCLA. It's endowed forever. You'll never have to work again in your life. I mean, and the people there don't work very hard. I'm telling you, I know them all very well. So it's one of the things that you guys might want to think of. There's a future that makes your life easier. Okay, any questions that you haven't covered? Going, gone? Yes?
To what extent are these associations, the data you were showing, is that on all of it on old people and old mice?
No.
Are these responses?
So the mice were young mice. The mice were young mice. The data I showed you with beta-endorphin said that older people actually respond better to a stressful exercise. But remember, these were people taken off the street and put on a treadmill and told to go as fast as they could. So that would have been a bigger stressor for an older person than a assumably more healthy younger person. Most of the stuff I showed you was caregivers. So these caregivers are 50 plus for practical purposes. So it was really looking at middle-aged and early older adults. So does that help?
Well, what that tells me is that there's no clear idea of the developmental sequence involved.
Except for the depression studies, which suggest that if you have depression early, you will get an increase in TNF. But, again, the data is limited. There is some data. They don't think of this as old people data. The neuropsychoimmunologists, while they include old people sometimes in their studies for caregiver stress, for instance, they they don't think of that they're doing aging. So they have a lot of data that looks similar in middle-aged people with who they usually study. Not a lot of studies in young people, but a lot of studies in middle-aged people. And the data looks very similar. It looks like if you get stressed, you screw up your immune system. Simple, easy way to look at it. Okay, that's all you really need to remember from the talk, if that's what's happening. But are there differences? The only one that we could show anything in was the exercise response, and it went in the opposite direction to what we expected. Okay, anything else? Well, we all knew it. Good, I'm glad you all knew about psychoneuroimmunology. I feel so much better that you knew this. Please don't forget about the screening test. Please, the psychiatrists in particular, don't forget about CST, and we'll let you know as soon as it's available, because you're going to be the biggest resource, I think, for people, and we'll see how well they do. The students are very excited about this. It will be done by medical students and social work students together, and so it should be very exciting. The beauty about CST is we can actually train almost anybody to do it. So you don't need high intellect to do it. You need high intellect to give Aricept. Don't ask me why, but you need no intellect to basically do the CST. So we're going to do much better, I think, with the CST. Okay, thanks everybody.